Right now we have a polypectomy case where the polyp is located exactly on the pylorus, which makes removing it a bit challenging. This location often requires more precision and patience during the procedure. Polyps on the pylorus can easily move with respiration, adding to the difficulty. The narrow space near the pylorus also limits the maneuverability of the scope. To start the polypectomy, we first perform an injection. The injected epinephrine helps reduce bleeding and lift the polyp from the surface, making it easier and safer to remove. The submucosal lift gives us a safer margin and improves control. With better elevation, the snare can capture the base more effectively. It also reduces the risk of deep dermal injury during cutting. Next, we insert the snare and place it carefully around the polyp. After confirming the correct position, we tighten the loop and use cautery. Accurate snare placement is crucial to avoid dermal injury to the pylorus. We always double check the snare orientation before applying energy. A stable position helps ensure a clean and complete resection. This polyp is unfortunately very firm and does not come up easily. So we release the snare and reposition it. Sometimes multiple attempts are necessary when the tissue is fibrotic or stiff. Repositioning helps us find a more secure grip on the polyp base. We try to adjust the angle of the scope to improve access. And this time we apply more force, and on the second attempt the polyp detaches and the removed piece falls next to the pylorus and into the stomach. We always monitor the detached specimen to ensure it is retrieved later if needed. Gravity often guides the specimen into the antrum, where retrieval becomes easier. We keep the field in view to make sure no bleeding starts immediately after resection. At this point, there isn't significant bleeding, but as a precaution and to prevent potential bleeding, we prefer to place on an endoscopy clips. Prophylactic clips is recommended, especially in high-risk locations like the pylorus. The clips help secure the resection site and minimize delayed bleeding. It also provides mechanical support while the tissue heals. However, the patient's advanced age, abdominal breathing, and some resistance make it difficult to maintain a steady focus for clips placement. These factors often extend the procedure time and require steady hand control. We carefully wait for the right moment in the breathing cycle to deploy the clips. A slight patient movement can shift the target, so timing is essential. Additionally, bile reflux slightly reduces visualization, which makes the procedure take a bit longer. flushing and repositioning may be needed to maintain a clear field of view. Despite the challenge, we proceed gradually to ensure a safe and clean closure. Clear visualization is key to placing the clips accurately on the resection site. Give me, give me saturation, please. Vital signs. Vital signs, give me. Thanks. Because of the heavy biliary secretion, foam and gastric flows, we need to perform irrigation before continuing with the clip placement. Irrigation helps clear the field and improve visualization. Without flushing, clip placement could be inaccurate or unsafe. Unfortunately, the secretion keep increasing and do not decrease. This makes it more challenging to maintain a clear view of the bleeding site. Despite the accumulation, we must act carefully and efficiently. Under this condition, we prefer to place the clip sooner while the patient condition is still stable. Placing the clip promptly minimizes the risk of delayed bleeding. The patient vital signs allow us to proceed safely for now. We need to be very precise to ensure the clip catches the exact point of the potential bleeding. Accurate placement is crucial to achieve effective hemostasis. After assessing the area again, it is necessary to apply one more clip for better hemostasis. Additional clipping ensures the resection site is fully secured. This approach reduces the risk of post-procedure complications.